Thank you for the kind introduction. I'm Myung from Samsung Medical Center. Today, I will present prognostic stratification after successful downstaging of HCC beyond the Milan criteria with implication for liver transplant candidate selection. This case illustrates our key clinical question. A young woman with cirrhosis and preserved liver function had HCC beyond Milan criteria. After 2 TAC sessions, imaging showed compact lipid uptake with no viable tumor and her tumor markers normalized. Do we recommend transplant now or hold off? After successful downstaging, LT clearly outperforms non-transplant management. In the Italian randomized trial, 5-year event-free survival and overall survival were both over 70% with LT versus about 18% and 30% without transplant. Therefore, EASL guideline recommended liver transplantation after successful downstaging from beyond to within the Milan criteria after treatment with local regional therapy and/or systemic therapy. However, LT is not always feasible, so in donor-scarce settings, we need to identify patients who can safely wait. In one retrospective cohort within the Milan criteria, having a single 2 to 3 centimeter lesion, complete response and AFP less than 20 after the first LRT showed only 1.6% waitlist dropout at 2 years. In our study of Beyond Milan HCC, downstaged with local regional therapy, we aimed to find a subgroup with survival comparable to LT recipients so that non-urgent LT can be safely deferred. This is a single-center retrospective cohort study conducted between 2008 and 2017, including treatment-naive patients with HCC beyond the Milan criteria without extrahepatic metastasis or macrovascular invasion, and with preserved liver function. For the primary analysis, we excluded patients who underwent upfront LT, participated in clinical trials involving systemic therapy with or without LRT, had bile duct invasion, missing 6 to 12 months response imaging, or underwent LT during follow-up. This is the patient flow. After excluding 399 patients, 1,043 beyond Milan HCC patients who received resection or LRT with 6 to 12 months response imaging and no LT during follow-up were analyzed. LT after successful downstaging served as the transplant reference cohort. Local regional therapies including RFA, TAC, TARE, radiotherapy, and combination modalities. Follow-up included contrast-enhanced CT or MRI and AFP, and treatment response was assessed according to modified RECIST. Successful downstaging was defined as achieving tumor burden within the Milan criteria after LRTs with sustained stability for at least 3 months. The primary outcome was overall survival. Baseline differs significantly between the resection and LRT group. The resection patients were younger, had less viral etiology, better liver function, and more often single large tumors. At 5 years, overall survival was 71% with resection comparable to the transplant reference cohort, compared with 38% with LRT. Among patients treated with LRTs, 65% were successfully downstaged to within the Milan criteria. Those who were downstaged had significantly better overall survival than those who were not. 5-year OS 51% compared with 13%. Among successfully downstage patients, multivariable Cox analysis showed that initial tumor size and number were not significantly associated with overall survival. In contrast, ECOG performance status and RB grade were independent predictors of survival. Notably, post-downstaging response, AFP at response assessment, and radiologic response were significantly associated with survival, with a hazard ratio of 0.57 and 0.33 respectively. Next, we constructed a prognostic nomogram using variables from the multivariable Cox model, selected for statistical and clinical relevance. The final model incorporated age, sex, ECG performance status, RB grade, baseline AFP, follow-up AFP, and radiologic response. For example, a 65 years old male with ECG 0, RB grade 1, baseline AFP 340, follow-up AFP 8, and no viable tumor after LRTs had a total score of 92, corresponding to an estimated 5-year overall survival of approximately 70%. Additionally, we constructed a decision tree model. We stratified patients into 4 prognostic groups based on radiological response, RB grade, and follow-up AFP. 5-year overall survival rates were 81% for patients with radiological CR and RB grade 1, and 64% for those with complete response and RB grade 2, and 46% for those with viable tumor and AFP less than 20, and 25% for those with viable tumor and AFP more than 20. Finally, this figure summarized the long-term survival in patients with HCC beyond the Milan criteria. In our cohort, resection and LT showed comparable outcomes. Among LRT-treated patients who were successfully downstaged with radiological complete response and RB grade 1, the 5-year overall survival was 81%, which is comparable with LT after downstaging, suggesting that LT can be safely deferred in this subgroup. In conclusion, about 15% of beyond Milan patients successfully downstaged after LRT achieved survival comparable to LT with non-transplant management. A prognostic model and a simple decision tree incorporating RB grade, radiological tumor viability, AFP at downstaging stratify long-term survival. These tools support LT decision-making in donor-scarce settings by identifying who should receive LT now and who can safely defer it. Thank you for your attention.